Innovations in CBT for Childhood Anxiety, OCD, and PTSD by Rizwana Khalil and Joshua Ortiz. Chapter 1, the Phenomology and Standard Evidence-Based Care of Anxiety Disorders in Children and Adolescents. So throughout childhood and adolescence, anxiety disorders are the most common mental disorders, with 2.5 to 8.3% of children experiencing such disorders. Despite the severity of this, anxiety disorders amongst children are often overlooked. The last 25 years of anxiety disorders within children have been researched rather than individual disorders. In clinical samples of anxiety disorders, most children had a specific phobia and anxiety disorder. The more distinct anxiety can be reliably diagnosed in children and adolescents, which helps tailor treatment and identify interfering problems. Children with anxiety disorders avoid certain environments that elicit fear and may engage in specific behaviors to increase their safety. Exposure therapy involves prolonged exposure to a feared stimuli until the reduction in distress is experienced. This experience is repeated between treatment sessions until the feared stimulus has acquired a new meaning and a strong response is acquired. The duration of exposure is sufficient at the point in which this violation has been achieved. Relaxation techniques for anxiety include controlled breathing, progressive muscular desensitization, or broader forms of muscular relaxation. Chapter 2, Evidence-Based Assessment. So overall, anxiety-informed evidence-based assessments has three considerations. They are context-dependent and multifaceted nature of anxiety conditions. Researchers are developing a framework for integrating data across modalities to assess anxiety response amongst the youth. Evidence-based assessments for anxiety vary in their psychometric properties and can be used for different clinical decisions such as screening, relevant anxiety concerns, monitoring treatment response, or monitoring the use level of anxiety. Many factors likely account for this gap, including the availability of evidence-based measures in clinical practice. Structured and semi-structured diagnostic interviews are used to determine if the youth meet the diagnostic criteria for anxiety. A wide variety of rating scales are available for assessing the youth anxiety, and rating scales are available for assessing youth anxiety in general. Chapter 3, Self-Help Treatment of Childhood Anxiety Disorders. Despite advances in research of self-help interventions for child anxiety, dissemination and uptake within the community remain suboptimal. There are several person-centered and systemic factors contributing to the poor uptake of treatment for anxiety by children and adolescents, including a lack of knowledge in identifying an anxiety, a problem, a lack of time, and concerns about confidentiality. Self-help treatments, including bibliography and computerized psychological interventions, provide positive outcomes for young people and their families. This includes increased privacy, reduced stigma, and greater use of autonomy. Recent research has begun to evaluate the optimal amount of therapist guidance required for child anxiety bibliography. A therapist-guided self-help resource was superior to a waitlist in primary diagnostic remission and symptom improvement, but not in the long-term follow-up. However, remission rates were similar in internet and traditional forms of treatment, and both were better than waitlists. A research project has been conducted on a program for treating children and adolescents that uses computer-based technology. The program involves providing the child or adolescents with a CBT program and receiving support from therapists via email, phone calls, and automated email system. Chapter 4, New Technologies to Deliver CBT. Computer, mobile, and internet delivery methods have been proposed as potential ways to increase young people's access to mental health treatment and preventative interventions. Cultural differences have been found in the way in which young people assess online content. The therapy is highly structured and consists of a series of clearly delineated therapy components that can be implemented in a sequential fashion or as elements within each session. A confounding factor of ICBT at home has was that the children and parents were slower to complete the treatment process, making it impossible to compare the longer-term outcomes. Some clinicians are worried about the I/CCBT and will negatively affect the relationship between therapist and client. But it would seem that this form of treatment, when accompanied by brief therapy support by email and phone, does not result in these outcomes. Chapter 5, Cognitive Bias Modification Strategies for Anxious Children. CBM encompasses interventions designed to modify two subclasses of processes. One is to attentional processes, and two is interpretation processes. In addition, CBM may also address memory bias or automatic action tendencies. However, despite the effectiveness of these treatments, approximately 72% of children with an anxiety disorder do not receive any form of treatment. Research suggests that anxious children and adults demonstrate a bias toward threat-relevant information when doing a probe detection task. This bias relates to an inability to disengage attention from the location where the threat stimulus has appeared and to redirect attention to the location of the neutral stimuli. Researchers have attempted to improve the ecological validity of attention training for anxious children by using visual search tasks. However, it is difficult to assess the mechanism of action in such designs because bias towards threat and bias towards positive stimuli are inversely related. This research suggests that anxious youth are more likely to endorse ambiguous information as threatening and less likely to endorse ambiguous information as benign. Chapter 6, Brief Intensive Treatments. Anxiety disorders are associated with substantial burden, life impairment, dysfunction, and reduced quality of life. Youth with anxiety disorders can experience distressing physiological symptoms. Many children who suffer from anxiety disorders do not receive any treatment, and those who do not receive treatment do not receive evidence-based treatments. Despite advances in the development of evidence-based treatments for anxiety disorders, many youth still do not show clinical response. Many families do not seek treatment at all due to stigma of being involved in lengthy psychological treatment. In addition to reducing missed sessions, delivering CBT across a relatively brief period of time may be useful for youth with complex clinical presentations. The severity of Comorbid anxiety disorders is reduced when there is treatment for specific phobia, and the severity of Comorbid anxiety disorders is reduced when there's treatment for a specific phobia. Chapter 7, Pharmacology Enhanced Approaches for Anxiety Disorders. Anxiety disorder treatment should begin with a thorough process of evaluation and a review of underlying medical comorbidities, physiosocial stressors, and developmental level. SNRIs are considered second-line therapy, although one is FDA approved for generalized anxiety disorder in children and adolescents. The medications such as beta blockers, alpha agonists, and antihistamines are also used for anxiety, but they lack data on efficacy and are limited in their long-term utility. Chapter 8, Enhanced Family Approaches for Anxiety Disorders. A common belief among children and adolescent psychotherapists is that parental involvement is essential to ensuring and maintaining change in therapy for childhood anxiety disorders. The family can play a role in development and maintenance of anxiety disorders, and the presence of anxiety disorders is correlated among members of the same family, and the odds of developing an anxiety disorder are increased if one or both parents have had this disorder themselves. Family factors including attachment, parent transmission of cognitions, interpretation biases, parental overcontrol, parental rejection, contribute to childhood anxiety. Involvement of parents in therapy seems intuitive, but the empirical evidence for its utility is not as strong as one would predict. This approach does not decrease exposure time. Chapter 9, Treatment of comorbid sleep problems in anxious children. In randomized controlled trials, review papers, and meta-analysis, CBT therapy is the most effective physiosocial treatment for childhood anxiety disorders. Youth with sleep disorders have anxiety disorders at alarming rates, and anxious cognition may be one salient pathway through which sleep and anxiety are connected. Children with anxiety disorders often complain of sleep problems, particularly in those with generalized anxiety. In contrast, children with social anxiety disorder or OCD experience similar rates of sleep problems in general. Children with other psychiatric disorders often experience these same sleep problems. Chapter 10, Transdiagnostic Approaches to the Treatment of Anxiety Disorders in Children and Adolescents. The development of disorder-specific CBT protocols has led to significant advancements in the treatment of anxiety disorders across the lifespan, but the growing number of CBT manuals can limit clinicians' training and dissemination of evidence-based CBT interventions. CBT for anxiety disorders aims to help the children recognize anxious feelings, thoughts, and bodily sensations, identify thoughts in anxiety-provoking situations, and develop more helpful or balanced thoughts or other strategies to reduce this anxiety they experience. Treatment of anxiety in children and adolescents between 7 and 17 years old can be delivered in either a group or individual session. The modular approach to therapy for children with anxiety, depression, trauma, and conduct problems is an example of modular transdiagnostic CBT protocol that uses a set of modules that can be used to target anxiety disorders, depression, trauma, and behavioral issues. Chapter 11, Dissemination and Implementation of Evidence-Based Programs for the Prevention and Treatment of Childhood Anxiety. For a particular intervention to be successful, it must be associated with better results, easy to use, adaptable to its environment, and its outcomes must be relatively easy to identify. The Consolidated Framework for Implementation Research proposes 5 major domains pertaining to the implementation of an intervention. A large-scale implementation project, the Children and Young People's Improving Access to Psychological Therapies Targeting Anxiety Disorders, Depression, Conduct Problems, Self-Harm, and Eating Disorders, has improved access to psychological services for 93% of youth. This CBT has significant impact on the children with anxiety disorders, with significant reductions in children's anxiety symptoms and clinical diagnosis. The decrease in symptoms is likely to translate into a reduction in the proportion of children meeting criteria for an anxiety disorder. Chapter 12, Innovations in the Treatment of Childhood Anxiety Disorders. In this chapter, we aim to explore the role of mindfulness and self-compassion approaches in the etiology and treatment of childhood anxiety disorder, particularly through a description of recent initiative to train mindfulness and self-compassion in children with CAD. The primary goals of treating children with anxiety disorders, including helping children recognize and manage anxiety triggers and simultaneously work to reduce physiological arousal. These approaches may decrease rumination and emotion suppression, increase positive emotions, and decrease psychological symptoms such as depression, anxiety, stress, and burnout. Chapter 13, Phenomology and Standard Care of OCD in Children and Adolescents. OCD is multifactorial syndrome that involves multiple genetic, biological, environmental risk factors that may involve multiple genes of small effect. Children with OCD may experience repetitive behaviors and/or self-stimulatory behavior more consistent with the autism spectrum than OCD, as well as a repetitive ruminating that one's past and future as secondary to generalized anxiety disorder. Children with OCD tend to have obsessions about separation and fear of harm, compulsions with obsessions, and rituals involving family members. Children tend to minimize their symptoms when compared to parents, and teens tend to have religious, sexual, and miscellaneous obsessions. Chapter 14, Evidence-Based Assessment of Children, Obsessive-Compulsive Disorder. OCD in children may co-occur with other disorders and may be characterized by ritualistic eating behaviors, a need to touch someone else, and a compulsive hair pulling. Comorbidity can complicate both OCD presentation and OCD severity impairment, school social functioning, and response to interventions. Autism complicates assessment of OCD, but can be differentiated from OCD by thought, content, and affective experiences. OCD may be mislabeled as ADHD and cause distractibility or concentration problems. Assessment of functional impairments associated with OCD can assist the clinician in understanding the full spectrum of OCD symptoms. Chapter 15, Self-help treatments for childhood OCD, including bibliography. Research on the use of physiological therapy for OCD in young people has focused on treatment delivery. Patient characteristics such as age, gender, ethnicity, and treatment history may affect the outcome of self-help interventions, with older adolescents responding better and vice versa, given the role family members play. To ensure effective interventions for youth, CBT or ICBT programs should be developed by researchers with grant funding. This requires careful management and consideration, and it may be a long-term government investment is required. Chapter 16, New Technologies to Deliver CBT for Young Children with OCD. The healthcare system in many countries does not detect most cases of OCD. The lack of insurance coverage or out-of-pocket treatments keeps patients from seeking treatment, and in some areas, the distance to the nearest clinic makes office-based CBT unfeasible. Innovative formats of delivery of CBT have been developed or are in the initial stages of development. The term IZBT refer to the interventions based on internet, video, or telephone conferencing, mobile phone applications, and virtual reality. The self-guided, fully automated ICBT intervention is self-directed, fully automated intervention for adolescents with OCD. Chapter 17, Interpretation and Attentional Bias Training. Current treatments for OCD in children and adolescents are effective, but not for everybody. On average, patients improve after 14 to 16 sessions of manualized treatment. Adding selective serotonin reuptake inhibitors to cognitive behavioral therapy in non-responders does not provide additional benefit, and the safety and long-term effects are unknown. Results show that CBMI added about training changed online interpretations during training, delayed negative OC-related interpretations coming to mind, and reduced OCD symptoms.
The first chapter I'm going to review is chapter 18, and it's called Innovations in Treating Obsessive-Compulsory Disorder. Now, CBT with exposure and response prevention is recommended and known as the first-line psychological treatment. CBT with ERP is highly effective for the majority of children, although there are a minority of 40% who don't achieve remission. And by remission, we all know remission is a stage of your treatment when you don't have any symptoms. The majority of children and youth with OCD simply do not have access to these evidence-based treatments for a wide variety of reasons. And one of the drawbacks of CBT is that it's time-consuming because it takes a period of 12 to 20 weekly sessions of clinic-based therapy. Scheduling of this CBT sessions, which tend to be like 12 to 20 weeks, or even just being there every week, can be difficult for families to manage with competing work or school or other activities, because everybody has different schedules. So it could be really hard for families to attend this OCD sessions, the CBT sessions, because as we know, when treating children, families really need to be there, and we have to prioritize for the families to be there, because if they can't bring the children, then there's no way of children attending these sessions. Now, things to keep in mind before providing CBT is that the clinicians need to ensure a thorough evidence-based OCD symptoms and severity. So the clinicians have to do an assessment of OCD symptoms and severity. Clinicians have to provide family with supports and family accommodations through regular check-in calls or weekly check-in calls, or they can just do a scheduled session just with the families. Clinicians also have to remember not to rush during the ERP or the exposure and response prevention sessions. And if you are a therapist who's just starting out, be sure to seek out advice regarding expert CBT trainers, just asking them and knowing what they would do if they were in your position. Chapter 19, Pharmacology and Augmented Treatment. Despite CBT has been proven to be effective in most cases, however, a significant number of young people do not reach to the state of remission from OCD following CBT. So basically, a significant number of young people may need more time reaching remission, or they might never reach remission. There is limited research to guide when and how to augment CBT with pharmacologic agents. Currently, the only recommended first-line medication for pediatric obsessive-compulsory disorder is called SSRIs. Now, research shows that anxiety disorders has revealed that SSRIs does not lead to additive benefits. CBT engagement may be compromised by comorbid disorders like depressions or externalizing disorders and family dysfunction. Now, I'm going to explain what comorbidity is in later slides, but it's basically when two or more psychological conditions coexist at the same time. Although there are a few studies of combined treatment outcomes in pediatric OCD, research across a number of anxiety disorders has revealed that the augmentation of CBT with SSRIs does not simply lead to additive benefits. We're now moving on to chapter 20, Enhanced Family Approaches in Childhood Obsessive-Compulsory Disorder. OCD is a serious psychological condition with childhood prevalence estimated to be 1% to 3%. So it can be anywhere from 1% to 3%. There have been tremendous advances in the treatment of pediatric OCD, and to treat OCD, exposure-based treatment can be enhanced with additions of family-based elements. Now, OCD sessions, like the CBT sessions for OCD, can be too much sometimes, and it can lead to high expressed emotions and other maladaptive communication strategies among family members. Family-based elements often include parent-centered skills, as well as with an emphasis on improving communication strategies among family members. So just to know that knowing how to improve communication skills can be really important, especially when there are a lot of emotions running during the CBT sessions. We're now moving on to chapter 21, Treatments for OCD and Comorbid Disorders. OCD is a serious psychological condition, as I have said before, and OCD is associated with other comorbid disorders, which may vary in mild to severe symptoms, and which may act as an obstacle for treatment and may require adaptation to the OCD treatment. And as I have mentioned before, comorbidity is like a state where two or more psychological disorders can coexist at the same time. Some of the examples of comorbid disorders are attention deficit hyperactivity disorders, autism spectrum disorder, Tourette's syndrome, and at the same time, anxiety and depression. Like all these symptoms can coexist together. And that's what we mean by comorbid disorders. A thorough assessment of comorbidities and their impact is required to determine which disorder to treat first. Sometimes OCD symptoms overshadow comorbid conditions, and this is why, in case there is a CBT failure, comorbidity should be reassessed, just to know which treatment should be treated first. And that's just like, as I have mentioned, that OCD symptoms sometimes overshadow comorbid conditions. So clinicians might have to start with reassessing comorbidity and which disorder to treat first. We're now moving on to chapter 22, transdiagnostic approaches. Pediatric OCD is a disorder that is highly heterogeneous. Some of the symptoms include cleaning and washing hands very frequently, several times. So if we see somebody who's constantly cleaning and washing their hands very frequently, that should be heads up that this is one of the symptoms of OCD. Somebody's very obsessed with cleaning their hands or cleaning other body parts or just the surfaces. Another example OCD is having thoughts and doubts, collecting and hoarding things. Therapists should pay attention to these symptoms, and clinicians should carefully evaluate available data, especially the pros and cons of when considering transdiagnostic approaches. Clinicians should consider their clinical judgment when deciding on which transdiagnostic approach is most appropriate for clients to develop their own theory-based approach. Clinicians should also remain flexible, monitor clients' progresses, and modify the treatment when necessary. Next, we're going to be talking about pediatric OCD. OCD is a complex condition associated with significant morbidity, comorbidity, and functional impairments. The effects of CBT for children and adolescents appear to be both robust and durable, and this is usually treated with a period of 12 to 14 weeks for most patients. The treatment of young children require a family-based approach. CBT involving ERP is an efficacious and effective treatment. When treating adults with OCD, studies found that there is a strong correlation between sessions, attendance, and CBT outcomes. So if a lot of people, like if a child or and their family are attending all of the sessions, the results will be positive. There could be like a faster pace to reach remission, and we might just notice that they're improving and their state of mental health is improving. Similarly, when there is a poor attendance habit, or if a family or children and their children are not being able to attend the sessions for whatever reasons, we could also see that their mental health may not progress as we might have liked it to progress. And we might have to readjust to their schedule to make sure that they are attending these sessions. Now we're moving on to trauma-focused OCD. Exposure to traumatic experiences is very common among children, and these experiences can be something very severe as sexual abuse and physical assault to something very mild where the children are just witness to other people being bullied and similar things. 60% of children in the US experience severe forms of traumatic experiences. While some children are resilient, others can suffer from psychotic episodes and other psychosocial difficulties. Early interventions can help with early childhood trauma. Research shows that support and emotional well-being of a caregiver is associated with positive outcomes for children. And there's still more to learn about the impact and treatment of childhood trauma. Frequent interventions will produce optimal outcomes for children and young adults with a traumatic childhood. We're now moving on to advances in assessing PTSD and the newer technologies to deliver CBT. PTSD was first defined in the 1890s in the DSM of third edition. And we all know what DSMs are. They're Diagnostic and Statistical Manual of Mental Disorders, and post-traumatic stress disorder was first coined in 1890s in the third edition of the DSM. Some of the symptoms are re-experiencing traumatic events and reliving traumatic events. Children and adolescents might be avoidant and or might take longer to share details of traumatic events. Therapists should be sensitive, focused, and compassionate to gather more information from children. And we might just have to, when we're providing therapy, we might just have to take time and the pace that the children have. There are newer technologies to treat CBT, and these technologies can be something like a mobile app or a web-based CBT or virtual realities. These forms of newer technologies has been proven to be beneficial to children and families with traumatic past. Chapter 28, Eye Movement Desensitization and Reprocessing, otherwise named as EMDR. So it is exactly what it sounds like. EMDR is like eye movement and of a client. And an example would be a clinician pointing their finger and hand and asking the client to follow where their finger and the hand is moving. EMDR is a trauma-focused psychotherapy method. EMDR might be faster than the CBT methods. EMDR therapy is appreciated by many clients as it is a gentle therapeutic method. It is an alternative to prolonged exposure, which involves repeated voluntary recollection of disturbing traumatic memory. And this can be a very stressful and demanding method, as we know, because prolonged exposure brings back those flashbacks or just those disturbing memory from a traumatic incident. And this can be especially not very helpful for children and adolescents. This is why EMDR is especially beneficial for children and adolescents, because it does not involve that process of remembering traumatic memory. EMDR is a time-saving method for PTSD, especially for children suffering from war and terror experiences. So like really those disturbing experiences, that's where EMDR is most effective. We're now moving on to chapter 29 and 30, Innovations in Early Trauma Treatment and Pediatric PTSD. Childhood trauma is a major public health issue which affects the lives of millions of children every year. And when this childhood trauma is left as untreated and they're left as unrecognized, it might become very overwhelming for children, and many children might never recover, and they might develop PTSD and other long-term illnesses. Examples of childhood trauma can involve interpersonal trauma, child abuse, accidental injury, chronic illnesses or injuries, or natural or human-made disasters. So any of this can be a really severe childhood trauma. And sometimes when they are left untreated and unrecognized, there are many poor outcomes that can result from it. And those outcomes can have adverse life effects, such as developing chronic PTSD, depressive and anxiety disorders, academic difficulties, alcohol and drug abuse, difficulties with forming intimate relationships, and it can also contribute to personality disorders and serious medical conditions. And this is why Farrell et al. Defines PTSD as a complicated condition involving dysregulation of multiple neurobiological systems influencing cognitive, affective, and behavioral domains of functioning. We're now moving on to chapter 31, enhanced family-based interventions for children who have been traumatized by physical abuse and neglect. Families with difficulties trusting will need significant work helping them to establish trust in order to participate in the treatment. So for families who are coming to the CBT sessions, we'll need to first establish trust. Therapists should be patient and persistent while engaging clients and their families, while understanding the client's background and family should be the first step. Therapists should also ensure that they know whether the client lacks social support and how to support with forming new relationships or friendship. With families under the monitoring of child protection services, safety should come first, and safety is a primary treatment goal, and therapists should ensure a safe space for the children and their families. Comorbidity is co-occurrence of two or more current or lifetime psychiatric disorders. And as I have mentioned before, comorbidity is coexistence of two or more psychiatric disorders. And these disorders can stay at the same time, and sometimes there could be more than two disorders. And two of the most comorbid presentations with PTSD are PTSD with depression, and the second one would be PTSD with substance use disorders. Traumatic stress is an experience and not a disorder or diagnostic. And it should be important to know that we define it as an experience and we're not jumping to the conclusion and giving it a diagnostic, because traumatic stress really is an experience. However, traumatic stress can lead to many psychological outcomes. For example, depression, anxiety, traumatic grief, aggressive behavior, and other externalizing and internalizing behavioral problem. And transdiagnostic treatment approaches such as CCT appear promising for addressing the many outcomes of childhood trauma. Dissemination and implementation of treatments for PTSD and the new wave therapies for PTSD in youth. We're now in chapter 34 and 35, and we're basically going to talk about dissemination and implementation of treatment for PTSD. So approximately 16% of youth exposed to trauma will develop PTSD. Impairments caused by childhood trauma may continue into adulthood with links to poor physical and mental health. There are many evidence-based interventions for children experiencing PTSD. One of the examples of evidence-based intervention for children can be a school-based setting, because school-based setting is an example of implementing evidence-based practice for childhood trauma. A lot of the children go to, because they're already in school, it might be beneficial just starting from the school, providing sessions at school while their families are present. Some of the factors to consider when providing therapy for children with PTSD are: clinicians must ensure that safety and trust has been established first. Clients should be reminded of their choice that they have a choice to participate and they have also a choice to refuse any activities. And clients should also be reminded that therapists need their consent before proceeding with an activity. Farrell et al. Mentions that clinicians might start slowly, increase gradually, assess regularly, and modify appropriately. And this really means that clinicians should be flexible and they should monitor clients' behavior and modify treatment as necessary. And as one of the things that come up many times is that when we're just starting out as therapists, we should always seek out advice from the expert CBT leaders or expert CBT trainers. And this can be one of the ways we can really improve our therapy sessions. Thank you very much for listening. This ends our presentation.